So what are the things which you will see that you go like, this one is not irritable bowel syndrome. So before we do that, I want to proceed that with the case. Can somebody read this case for us, please?
I can read. 55-year-old male with chronic abdominal pain and altered bowel habits. 55 years, chronic abdominal pain and altered bowel habits. Which of the following features is not considered an alarm feature in patient presenting with symptoms suggestive of irritable bowel syndrome? Age of onset after age 50 years, nocturnal diarrhea, elevated C-reactive protein, family history of irritable bowel disease.
Beautiful. You read it so beautifully, doctor. Thank you so much. Sure. Is it A? Is it B? Is it C? Is it D? What are you going to go for? Red flags, red flags, red flags. So which of these is not a red flag? That's the question. Which of these is not a red flag? Gotten 30 answers already. And a lot of people are going with D, 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 D. The answer is D. Alarm features are clinical indicators that suggest the presence of underlying organic diseases rather than functional disorders like irritable bowel syndrome. So one of the alarm features is if you have a patient who is, say, 60 years, who starts presenting with alternating bowel habits, boom, you should be concerned. Could this patient have colorectal cancer? Number two, if you have a patient who has nocturnal diarrhea. Number three, you have a patient who has elevated C-reactive protein. Remember that we said that all the labs we do in irritable bowel syndrome are to rule out other conditions. So I have a question. I said something unique about C-reactive protein. Who can remind me about when is the time we do C-reactive protein? I said something unique about it when we're dealing with it.
You said when calciprotectin, fecal calciprotectin and fecal lactoferrin is not available, they reduce C-reactive.
Beautiful. So you see, step by step, we are building on our knowledge, and it's really, really helpful. It's good that I see everyone coming along. So, what are the alarm features of irritable bowel syndrome? Number one, age of onset after 50 years. Number two, rectal bleeding. Number three, nocturnal diarrhea. Number four, progressive abdominal pain. Number five, unexplained weight loss. Number six, abnormalities on labs like you see iron deficiency anemia, you see elevated C-reactive protein, you see fecal calprotectin, you see fecal lactoferrin. You see these ones, no, this patient does not have irritable bowel syndrome. Family history of inflammatory bowel disease or family history of colorectal cancer. So if you have somebody with Crohn's disease, that's not irritable bowel syndrome at all, unless you make sure that that patient does not have Crohn's disease. So please master the red flags. Red flags, red flags, red flags are very critical for you to master so far as this exam is concerned. So these are some things you want to do. If you see anyone with any of the red flags, first you want to make sure that you do an endoscopy. An endoscopy is for sure. You want to do it. If you have somebody who comes in with diarrhea and the diarrhea is like a nocturnal diarrhea and it's causing you to think, hey, does this patient have red flags? Boom. You want to do colonoscopy and biopsy to assess for inflammatory bowel disease. Okay? And when will you do CT scan in a patient who is presenting with alarm features of irritable bowel syndrome? If there's a clinical suspicion for structural lesion, so maybe if there's a colonic tumor or something, then you want to do an abdominal CT. And if the patient has abdominal pain, look at this combination very well. Abdominal, so I give you an example. For example, 65-year-old female, abdominal pain with bloating and early satiety and constipation. What diagnosis will come to your mind? Abdominal pain plus bloating plus
ovarian cancer.
Oh my goodness, Dr. Ma, you killed it. Ovarian cancer. 65-year-old female, abdominal pain, bloating, early satiety, constipation, ovarian cancer. That's why you want to do a pelvic ultrasound with or without abdominal CT scan. Dr. Ma, that's powerful. I'm very, very happy.
That's how we do it in Magneto.
It's like you're solving a math equation, right? You see this plus that plus that. Boom. It should tell you what you're dealing with. So I'm very happy about the way you picked that up. That's good. Okay. So now What are the differentials of irritable bowel syndrome? Differentials of irritable bowel syndrome. The differentials of irritable bowel syndrome can be infections. And what one infection did we learn that we need to screen for in irritable bowel syndrome? Can somebody tell me?
Difficile?
No, before difficile.
Giardia.
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 Lambia.
Yeah.
Lambia. Lambia. Exactly. Inflammatory bowel disease, like Crohn's disease, right? Anxiety, because anxiety disorder is also associated with it. Malignancy, like colorectal cancer, hypothyroidism. Okay, so I have a question with the diarrheal type and then the constipation type. Which form will a patient with hypothyroidism present? Will the patient present with diarrhea or constipation?
Constipation.
Constipation.
Beautiful. And there can also be malabsorption, lactose intolerance, Crohn's disease, celiac sprue, and then drug-induced diarrhea and constipation. So I have another question. Which drugs did we learn can cause diarrhea? Can you give me two? And which drugs did we learn can cause constipation? Can you also give me two of them? I want a volunteer. So you see now,
Constipation. Tricyclic antidepressant.
okay,
Antipsychotic can cause constipation.
okay. And what else? A common medication for pain management, or a common class for pain management that can also cause
Opiates.
opiates. Good. Okay, now let's go to diarrhea. Which drugs did we mention can cause diarrhea?
Digoxin.
Toxin. What else?
Macrolides.
Macrolides. Beautiful. What else?
Amoxicillin.
Angiotensin conversion
Inhibitors.
Amoxicillin.
Angiotensin converting enzyme inhibitor.
ACE inhibitors, amoxicillin. So you see, doctors, everything we learned initially is coming together. So whether even in your NAC exam, you are taking a history of a patient with, alternating bowel habits, you should demonstrate all this. You should go through, have you traveled recently? Is there a family history of inflammatory bowel disease? Is there a family history of Crohn's disease? Are you going through any anxiety? Has there been any sudden weight loss? Has there been any night sweats, any lumps and bumps on the body? Do you feel cold when all other people feel warm? Have you noted any swelling in the neck? Have you noted any dryness of the skin? Any gritty feeling in your eye? Does your stool float on water? Do you pass a lot of stools and gas after you take milk? When you start demonstrating knowledge like that, man, it's beautiful. It's beautiful. Doctors, please, I have a question. Is the class making sense now?
Yes.
Yes.
Sadly.
Yes.